name's Joy Dawn. I'm part of the NEST team here, and I've worked on newborn care, particularly in Africa, over the last 25 years or so. So one of the things about NEST is that it's very fast-paced and scary, but one of the things that gives us great hope for being able to make the change that we need to make in the next 10 years across 46 countries in Africa is looking at the giant of India. So India has the unenviable #1 for newborn deaths. But India has an enviable #1 for rate of change for building special care neonatal units across the whole subcontinent. And that has come about through having a vision, through having ambition, through a team of people. But there's one particular person who's played a very special role in that, and that is Dr. Gagan Gupta. So we're really fortunate to have Gagan here today. He's a medical doctor in India, worked with UNICEF, started small, and has found ways to pull strategic levers to bring change across the whole continent. So I'm going to hand over to Gagan. Please take us through this talk. And for those of you from NEST, last time we had this talk, I think there was a standing ovation. But we've asked him specifically to talk about the money, the investment. What were the levers that could be pulled to make that happen? Over to Gagan.
Thank you, Joy, for this very kind introduction. And you are one of the reasons why I'm here today. And to the wonderful NEST team and the RISE University for hosting me, a very big thanks. A very warm greetings to all of you from UNICEF and from India, where this piece of work and I come from. But before I start, let me also acknowledge the presence of Dr. Miki Chopra. He was the Chief of Health for long in UNICEF. And he was one of the role models for us and has been a guiding force for all this work. Thanks, Miki, for staying back for this talk. Over the next half an hour, I would take you through the story of India's newborn care unit. A story which not many believed a few years back can be written by a low middle income group country, to virtually breaking the glass ceiling in 2018 by reaching 1 million newborns in a single year. It's also a story of moving from a UNICEF pilot in few districts to a national scale-up through the strong government leadership and government financing, with nearly $100 million coming in 2019 alone, and more than $500 million invested till now by the government of India on special newborn care units. It's also an example when strong leadership merges with the right partner support and brings the right intervention which is needed on the ground, can find a very quick buy-in in the system and can be scaled up. As Joy said, the story of India is often told as a story of large numbers. It's a story of 25 million babies born each year, by far the biggest birth cohort. The next is China at 17 million. The narrative will not change that India contributes to maximum number of newborn deaths. But what has been changing over the years is the share of India's neonatal deaths to the global burden is decreasing. It was 31% in 2000, and now it's 22%. 5 years before, when I used to show this graph, India's number alone were more than the other 4 countries in the top 5, Nigeria, Pakistan, DRC, Ethiopia put together. But now that gap is reducing. And the two now most worrisome countries would be Nigeria and Pakistan because of the comparatively slow progress. We have worked for all these years in the community, and so did we when we started our work in 2007. That was right at that time because women were delivering in home. The pioneering work from Dr. Abhay Bang on the home-based newborn care. That was very much relevant, and that is relevant today as well. But what is happening is the narrative is changing. The place of delivery is changing. And our newborns are shifting from home to hospitals because the moms are now delivering in these health facilities. In 2005, every second woman was delivering at home. But now, in 2015, the institutional delivery became 80% in the country, with 8 out of 10 women delivering in home. The effectiveness of the IMNCI and the other programs meant more referrals coming to the health facility. But that also meant that are we equipped enough to maximize the gains of facility access for newborn survival? And as we all know, investing in small and sick can reduce the neonatal mortality by 30 to 50%. And that's one area which is something which was critical and which was missing. This was the situation when we started the work of the facility-based newborn care. You can see the newborns lying open in the health facility, newborn being given tea, and that too with a dirty twig from the mattress, these kind of makeshift phototherapy machines. And the situation in the private sector wasn't even better. Private sector, very few beds, that too in the bigger metro cities. The cost of care made it inaccessible to poor. And within the hospital management, the more lucrative were the neurosurgery and the cardiac surgery, which were the more money-minting departments as compared to newborn care, which takes more space but get less returns on investment to the private sector. So the big moment for us came was the launch of National Health Mission in 2005. It got two things. It got the resources, both the financial and the human resources for health, and it also got an opportunity for piloting innovations and decentralized planning where districts can invest in these innovations and that can be then taken up for scale. The focus was to converge interventions around birth to get the triple returns on investment for reducing maternal mortality, neonatal deaths, and stillbirth. And earlier in the day, Mickey was speaking about transport and access. And this was one of the important things. And I will come further in my talk when I will discuss the outbound mortality versus the inbound mortality and the need for investing in the transport system to bring women in time to a health facility. Making sure that every baby gets early and exclusive breastfeeding and essential newborn care. But those who are small and sick receives the special care, and wash and nutrition is integrated in the health facilities and in the newborn care unit. What also was important was this whole setup of transport system. This work is often not spoken of, but this work is equally important as the work which we did on the newborn care units. We created a network of vehicles posted in the peripheral villages, which were bringing sick women, pregnant women, and sick children and sick newborns to the health facility with a centralized call center. And we were able to transport nearly 1 million pregnant women each year in a single state through this 24/7 network of ambulances. And half of them were transported between sunset to sunrise when the access in the village is at its minimum. And this was the level where there were 3 levels of care which were decided. One is to have a newborn care corner and resuscitation at all delivery points, a stabilization unit at sub-district level, a level 2 unit, and to bring a kangaroo mother-father care unit in the vicinity of SNCUs. And this is the champion for kangaroo mother and father care. So I haven't taken the permission for the photos from 2 of them, but this was along the sidelines of the Panama meeting when Joy and Stefan advocated for 24 hours continuously for prolonged kangaroo mother care. Now, this was the way we started. We started between 2007 to 2009 with a pilot funding. But even in the pilot, we made sure that though the infrastructure and equipments came from UNICEF, the human resources and the running cost commitment came from the government. That brought them into the planning board, that brought them into the ownership level, and that was very critical. Also, what was critical from the funding point of view was this was done with a very flexible funding which was available to us from the Norwegians and IKEA. And as a donor, it's important to keep a funding bit flexible. Otherwise, when you tie the funding too much, then we become a project rather than creating a big thing which can change the future. Now, 5 core areas for financing were taken into account while moving ahead. The first and the foremost was infrastructure development and standardization of infrastructure. And for the first couple of years, that is the major expenditure. The second was equipment procurement, and not only procurement, but ensuring the maintenance cost is also inbuilt. The third piece is the human resource, recruitment, skill building, and on-job mentoring and supportive supervision. The fourth was developing a data system and ensuring survival beyond discharge and ensuring early interventions if required. And lastly, the recurring cost, the cost on medicines including oxygen, consumables, electricity, lab, radiology, and housekeeping. And what is important is that we added the budget lines for each of them in the district plans, the state plans, and the national plans. So the national plans of health mission reflected a broader activity called facility-based newborn care, with a subhead on infrastructure, a subhead on human resources, a subhead on data systems, and subhead on the running cost. And you need to work on all these things simultaneously and not sequentially. Often the easiest thing is to order for equipments, but by the time equipments arrive, the infrastructure is not ready, the human resources are not there, the data systems are not there. So you need to work in tandem to make sure that you don't work sequentially but simultaneously. Now, I will go more in detail because I think it will also benefit the next implementation teams when they are planning ahead. Infrastructure, what do you need to factor in when you are costing for the infrastructure? The biggest cost implication is whether you are going for a new construction or you are upgrading an existing health facility. There is a huge lot of difference in the cost when you are upgrading versus when you are creating a new ward, because often the space is a constraint and no one wants to give us space even if it is there in the district hospital. The second is, please factor into the piped oxygen supply as well as the electric upgrade cost. You will need them, and electric upgrade is an important thing. There have been incidences of fire in the newborn care units because invariably you are adding 50 to 70 kilowatt power load in a newborn care with a wiring which is not very strong, and it will need a proper electric upgrade and also to prevent your equipment breakdown due to power fluctuations. The third important thing is getting the space right, and that is the most important thing for the costing. Now, what should be the optimal bed capacity of a unit? You need to make sure you don't come with a very small unit so that it is not very cost efficient, versus you don't come with a big unit which remains underoccupied. Basically, the optimal bed capacity is a function of delivery load and referrals. So what deliveries are happening in that particular facility will nearly constitute half of the admission in the newborn care unit. And half of them will come from the referrals, either through a peripheral delivery point or the IMNCI or the ICCM program. And then average duration of stay. As per our data of 5 million babies, the average duration of stay in India was 5.7 days. So factor in a 7-day average duration of stay, see the delivery load and referrals, and target for 80% bed occupancy. Leave 20% space for population growth, for increase in the institution delivery, and especially in sub-Saharan Africa, when the institution delivery still has to go up from 65% to much more, about 90%. Second is, you need to standardize the essential services in the design. First, standardize what you need, and then find the space to fit those services. Generally, as a rule of thumb, you need 100 square feet per bed plus support services, and I will come to more details when I am going on the floor plans. So 50 square feet for one bed plus 50 square feet support area, so 100 square feet per bed, and the practical rule of thumb is a 20-bedded unit can cater to 1,000 admissions per year with an average duration of stay of 6 to 7 days. As I said, you need to make the adequate provision. You can't make the space too cramped with the babies too near to each other. You need to have a free space for the staff to move to provide the care to the babies. And these are some of the units which shows how this is a proper area where the shoes are taken out, the gowning in, hand washing. And this is the design or a prototype for a typical newborn care unit. So the essential services that you need to include in the SNCU design, and then the country technical expert group can look into it and adapt according to the requirements which country feels is best for them. But as a generic thing, you need to have a place for triage or receiving the baby, hand washing station, a reception or an observation desk, a patient care area which I said is nearly 100 square feet per bed, step down, kangaroo care, breastfeeding support, if it's a tertiary level unit, even a milk bank, mother's ward, and a follow-up clinic. And then you need adequate space for support services like oxygen, stool, linen, autoclave, side lab, duty rooms, and toilets. But support space is equally important. Do not neglect on that, otherwise you will not be able to have a functional unit. So 2,000 square feet for a 20-bedded unit and add another 2,000 square feet for all the support services. So roughly an area which is required to start a 20-bedded unit will be 4,000 square feet. And then you can provide 2 or 3 prototypes depending on what kind of space is available. You can have a prototype for a square space, a rectangle space, and then the countries and the districts can adapt according to the availability of the space. Now, coming to the second point, after infrastructure, in the first years, the second biggest cost implication is equipments. Now, costing for equipments is comparatively simpler. You have a standard rate list by which you can come to the cost. But what is more important is you define what is essential versus what is desirable. Because you cannot have everything under the sun what you want for a newborn care. But what is important to take care of 90% of the newborns will be important. You may like to have a cranial ultrasound. You may like to have an ECG machine, EEG machine. But these are all desirable. These are not something without which you cannot run a newborn care unit. But what is important is radiant warmer, phototherapy, basic infusion pumps, pulse oximeter. So define what is essential, what is desirable. Sit with your country implementation technical teams and divide this into essential and desirable. Keep a buffer stock of 20% because many times equipment break down and it takes time. It takes time for help to arrive. It takes time for equipments to appear. I was in a few weeks back and 90% of the equipments in a wonderfully designed unit were non-functional. And there was no mechanism of getting the equipment right. So keep a buffer stock so that in case there's a breakdown, you will always have. Factor in the annual maintenance contract and the annual maintenance cost for 3 to 5 years. But what is important is let the district people know that there is a provision of annual maintenance contract and who is the person to be contacted. Many times the companies supply, we pay for the maintenance cost, but you don't know whom to contact and they don't turn up. And that leads to a lot of frustration within the districts. Need for partial replacement after 5 years. Do factor in that some equipment will run out their life in 5 to 10 years. So you will have to replace around 20% of the cohort after 5 years, and that needs to be factored in. Training cost for the equipments can be included in the supply orders. And don't forget to factor in the cost for generators, power stabilizers, oxygen cylinders. Oxygen cylinders is a huge burden because many districts don't have the bottling facility and the vehicle has to go 3 hours away to the neighboring district to get the oxygen bottles. So have enough number of spare cylinders so that you have to have less number of trips. Fire extinguishers, lab and radiology equipments. So these are the things which you need to take care while you are factoring in for the equipment costing. Now coming to the third most important thing is the human resource needs for the spatial newborn care units. When we started the work, we had a dilemma, whether we redeploy the existing staff versus we hire a contractual staff. There are pros and cons of both the things. In case of existing staff, they are often overworked. Many of them have lost motivation. And it's a total transition from working on-call basis to a shift duty where you have to be constantly in the newborn care unit. With contractual staff, it's always an issue of attrition. It's always an issue of how they are going to gel with the regular staff. So what we decided was that first let's set the HR norms. What is required to run the unit? And then get it through a mix of contracting. And if we are not able to get enough people on contract, then request the regular people to step in and then give them special allowance for the newborn care. So this was the staffing which we did, 4 pediatricians. With staff nurse, the simple rule of thumb is number of beds is equal to number of staff nurse. Because if you want a 20-bed unit, have 20 staff nurses, divide them into 3 shifts, keep a weekly off provision, and you will have a bed nurse ratio of 1:4. So that is a thumb rule that number of beds equal to number of nurses, divide them into 3 shifts, you will get a nurse bed ratio of 1:3 or 1:4. The lab technicians, we did not create a separate lab, but we strengthened the existing lab. So the existing lab was closing at 2 o'clock. By putting the 2 technicians, the same facility was used for evening and night, and the services were available to the whole hospital 24/7. And as Mickey was saying, that this will have a ripple effect. So this ripple effect will also have on the pediatric care and the maternity care once you strengthen your laboratory support. Ancillary staff is very important for ensuring sepsis prevention and cleaning of the units, security guard, electrician. In terms of biomedical engineer, we realize that keeping at district level can be an overkill. So one of the options can be to have a regional where 4 or 5 districts together can have a biomedical engineer who can support the 5 districts. If required, within a region, you can have an equipment repair center so that the equipments which are broken down can be sent to a particular region at a cluster of 5 or 6 districts, or the biomedical engineer can make visits to the district and sort it out. And we added this later because in the initial part, we were not aware that we will require a biomedical engineer. So many of the things evolved over a period of time, and we added them as we moved forward. And most importantly, it was a clear directive from the government that the entire staff will be put for SNC duty, because we didn't want it that once we train them and then they go to a surgical ward or a medical ward and all the investments on training goes away. It did happen at times because the civil surgeons are under tremendous pressure and the hospital superintendents to manage different faculty. For them, everything is equal. But as far as possible, we try to reinforce at every review meeting that the SNCU staff should not be put to rotation. Now, what helped us in getting the HR? The first and the foremost thing was we decentralized the recruitment and started the walk-in interviews. Initially, the recruitment used to happen at the provincial or the state level, but we made it at district level and started weekly walk-in interviews where on every Tuesday, a nurse can walk in, give the papers. If the papers are right, she can be recruited. And I talked to the government people there, and I said that when people need the job, you don't give them the job. You said we don't have a vacancy advertisement right now, it will come after 6 months. Someone else will hire him or her in the private sector. So it's important to be flexible, have an opening. Difficult area allowances were introduced. You quote, we pay policy. In some of the districts where we were not getting doctors, there was an open-ended advertisement where pediatricians and nurses were asked to quote what salary they would like to, and that was given as an open-ended salary. Enforcement of 2-year service bond for the fresh postgraduates, time-bound regularization plan for contractual staff. And many of the contractual staff and many of the people who were on bond, they ultimately ended up becoming the regular staff and not leaving the unit. Retaining the trained staff even after regularization. Many people were transferred to another district when they got a regular job. But even in that district, the government ensured that they were put in the SNCUs and not in a surgical ward or a medical ward. Task shifting and increasing in the retirement age. And this is what I was speaking about. This is the state with 200 million population, largest number of neonatal deaths in the country. Nearly 25% of the neonatal deaths happen in this single state. And you quote, we pay. Urgent requirement for specialists, and the suggestive package was a high base salary, added the intensive care allowance plus difficult area allowance, and everything was funded through the government budgets. And this is the comparison of the bed nurse ratio in different states. So what we had advocated was 4:1, one nurse handling 4 beds maximum. And you can see the variation across the country, and these are used in the review meetings. And I remember one of the states which are here at 4, they were somewhere around 7 and 8. But when this was reflected, the mission director and the secretary worked for next 2 years to bring a huge HR reforms to make sure that they are able to rope in the adequate number of nurses. So monitoring this and taking this in the review meeting and highlighting this also helps. So the key lessons on the HR was there is no single solution. You have to have a multi-pronged approach. Decentralization is important. At many places, still the recruitments are happening at the national ministry or the provincial level. Delegate it one by one to one level down. Open door policy, flexibility in place of posting, and never assume that you will not get them. The biggest mistake we do is we say, oh, where will you get the doctors and nurses? You first factor in that we need this, and then try to change policy piece by piece, step by step, and slowly you will be able to get them. But don't make the mistake of thinking that you will not get them. I will give you 2 examples. I was once in a private hospital, gone to see one of my relatives, and it was around night, around 9:30, and the nurse was doing some dressing or procedure, and I was standing outside. I was talking to a nurse who was on the reception, and I just asked her how much salary you get here. It was one of the top corporate hospitals of the country. They said we get $200. I told them that government is giving $300 and we need nurses for newborn care unit. Are you willing to join? She said yes. My second question was, My second question was, how many of your friends will come? And how many you can mobilize? She said 10. I said, done. Give me your contact number. I went back to the collector of the district. I said, there are 10 nurses who are willing to come. They need only two things. Take out their salary on 1st of every month. They can't wait for 3 months to pass to get their salary. And give them one house where they can live together. The collector did it. And all the 10 nurses within a month left that corporate hospital and joined that private hospital. So there are people who are willing to come. We need to have a proactive hunt for those people. Same way, one of the times it happened that there were nurses. I was taking in one of the district hospitals. I was going around in the ward and I was very frustrated because we had started a maternity wing and we were not getting adequate nurses for the maternity wing. So we just sat down and called all the nurses there. And we asked them simple question, how many of your friends want a job? You won't believe at least 10 to 15 of their friends wanted a job. We requested the collector, next fortnight we arranged a walk-in interviews and 15 nurses joined the system from different places. So there are people we need to proactively hunt out. So never assume that system does not have enough doctors and nurses. Yes, they are suboptimal, but you can start and then you can add up. But what is important is our plans should have the provisioning for salary once the people are there. Otherwise, if we under budget for that, it will be difficult. The third thing was the biggest, just in terms of the operational cost, the HR salary becomes the biggest pie after the first few years. So in the couple of years, initially it's infrastructure and equipments, but later on, more than half of your cost will be the human resource salaries. The drugs, oxygen and consumables will be the second highest. Equipment maintenance and repairs, housekeeping, follow-up care. And what also we did was we made a provision of the untied fund. So every district superintendent was given $20,000 of untied fund, which he could use for running costs besides medicines and salaries. So that if there's anything in the unit, and that money was delegated at the level of the unit staff with a small committee made of the nursing in charge and the doctor in charge and the superintendent. And they could use their money to plan the things in their own unit. And that is still there in the system. And this was our result. So starting from a pilot in 12 districts, which was a multi-state pilot supported by the IKEA and the Norwegian funding, to now national scale up with nearly $500 million leverage over this much period of time. And what does this mean in terms of the coverage? The map which I showed you with the bullets, that was 12 units initially. And now 82% districts in India have a special newborn care units. A part of Northeast and a part of Chhattisgarh and Telangana is something where we need to do more, otherwise we are doing pretty well. In terms of the numbers, starting from 250,000 to reaching 1 million plus. And this number is going to grow exponentially because still few units started in the last couple of years, they have not reached their full capacity, and this number should end up touching 1.5 million in the next couple of years. The funds that were leveraged for SNCUs, and this is the amount of funding which came from the National Health Mission. This includes the infrastructure cost, this includes the equipment cost, this includes the HR cost and the maintenance cost. But it does not include the cost of medicines and consumables, which is add-on to it. And this was provided through the state budget because the National Health Mission funds the states on a cost-sharing basis. But in addition, the cost of medicines and consumables was budgeted under the state health budget. Now, what were the key learnings from all this? It's basically an interplay between the establishment and the running cost. First couple of years, establishment cost takes over. Remaining years, it's more about the running cost. The most important thing is get your bed strength and the optimal HR right. Do not underutilize a unit. You won't gain much by starting a 4-bedded district level unit because you are going to put doctors, you are going to put nurses. If a doctor is there as well, he can see 12 to 20 patients rather than just seeing 4 babies. Pilots can be donor supported, but you need to integrate government even in the pilots. Take commitments from the government that if we put the investment on equipment and infrastructure, will they take care of the salaries after the second year? Scale up is best done through government resources. In countries where governments are still not willing, one of the mechanisms can be the pooled partner funding can be dedicated for this. Like I will give you an example of one of the countries where $25 million of the pooled partner funds was taken for equipments, and equipments have arrived with no plan to use. This money could have been used as a pooled fund for a systematic scale-up of the newborn care units. So even if the government does not have the resources now, the pooled partner funding, the swap mechanism which used to exist, or other funding mechanisms can be used. Setting up the budget norms in the government plans help in standardizing cost. And getting these budget lines incorporated in the district, national, and state plans is critical. And you have three mix of use of resources: a district level resource, a state level, and a national level. And this is the guideline which we had from Government of India. And this is the cost of SNCUs put in a government document. So whenever a district is planning, they would straight away use this cost. This was an approved cost by Government of India, and the national plans will approve the same. And we tried to do a bit of a costing exercise. This was a paper where I was also a co-author. We had 4 newborn care units in India, and we tried to see the cost analysis of the newborn care delivered to district level hospitals in India. And what we came to a conclusion was it requires nearly $110 per baby admitted and around $20 per bed day, because we have an average duration of 5.8, 5.9 days of stay. And that holds roughly true even now. This was in 2013. But on a rough estimate, $150 to $200 per baby who is admitted and treated in the newborn care unit is the current cost. And in terms of establishment of a new newborn care unit, the cost is around $150,000 as a single time investment. Now, after doing this, the next big question was, what's happening to these babies and how are these babies and the units performing? And that led to the starting of the SNCU online monitoring system. We started it again with just 2 units in Guna and Shivpuri in central India, but within 5 years we scaled it up to 90% the newborn care units. And now we have moved to the private sector with 100 units of private sector reporting data online, and totally we have 940 SNCUs online with nearly 5 million babies registered and nearly 500,000 deaths enrolled real time in the database. And the first step for that is get a data clerk in the unit and standardize data recording. You may digitalize it later, but what is important is all units should be recording the same variables. So we have a standard admission sheet and a standard discharge sheet. And this can be adapted in country context. The country technical advisory group can look at the basic sheets and they can adapt according to their need. Like in India, we were not using chlorhexidine. So now when it goes to Africa, chlorhexidine has to be added. HIV was not a big issue in India, so the maternal ARV treatment was not captured. So you can adapt according to the need of the country and the context, but the core will remain nearly the same. And then the most important thing was, how do you use this evidence to guide your future investment? And I will just give you 5 examples. The first was the investment around care seeking for the girl child. In 2019 alone, there were 194,000 fewer girl admissions in the newborn care unit in India. And India is the only big country to have a higher under 5 mortality for girls as compared to boys. If you see in Africa or if you see globally, the under 5 mortality for boys is much higher than girls. And this is in spite of free care being provided by the government. But the access barriers, the out-of-pocket expenses to reach a health facility, the wage loss during the 6-day stay of the family, all these adds and the value of the girl child in the society. The second important thing was, as Mickey was saying earlier, investment on infrastructure, roads and transport. This is the mortality between the outborn babies and the inborn babies. And the mortality in outborn referred babies was 1.8 times more than inborn. And this is the data of last 3 years, 3.2 million babies. It's a huge sample size. So once the baby is not stabilized adequately at a peripheral facility, which is ill-equipped, the human resources are not well trained for resuscitation, they don't stabilize the baby, and the baby is just sent in an ordinary vehicle to the facility. By the time the baby comes, baby is cold, gasping, and just bound to die in the district level facility. And that's why a combination of building the capacity of the peripheral health facility and your newborn care units can be the hub to build their capacity. They can come and work as 2 weeks observer there, learn the skills. That will also help them to know that there is a functional unit and where to refer and how to refer. Plus a transport system. Ultimately, we will need to invest in the transport system for pregnant women and newborns. The third thing was the CPAP. Especially I have taken this slide because of the work you people are doing. if you see the disease-specific mortality rate, the overall mortality in the SNCUs in India is 8.8%. But in cases of RDS, the mortality is 17%. So it's nearly the double the mortality. So if you want to reduce the neonatal mortality in the newborn care units, you will need to invest in the antenatal steroids, the whole gamut of preventing prematurity, plus more immediately in things like CPAP and surfactants. Mickey again spoke about quality of care, and this is one of the biggest examples. For years, we didn't go with PSBI treatment and gave gentamicin to community workers just because of the antibiotic resistance. But see the amount of antibiotic which is being misused in the health facilities. This has now come down significantly. It was a few years back touching 70%, but constant monitoring has brought down it 53%. But there are 59 SNCUs in the country where antibiotic use is above 90%. And that is the target now, to make sure that we come down on that. Another thing is the bed occupancy rate. So getting the bed size and the unit size right is very critical. You have units in Jharkhand and Punjab which are underutilized, while you have units in central and eastern India which are overutilized. And that's why initially we were not including KMC, but now for last few years, KMC has been included as a part of the newborn care so that the stable babies can be kept in the KMC, and the unstable babies, the moment they are stabilized, can be brought out earlier. Lastly, what we realized was it's not important to save the babies only in the newborn care unit. You need to extend this continuum of care back to the community, the place where they come from and the place where they go back to. That's their homes and the huts again. And this says, why is the need? We are discharging the babies still when they are not 2 kgs. So every 1 in 4 newborn who was discharged in last 3 years was below 2000 gram. That meant it needed still hypothermia prevention, infection prevention, care for the feeding, and referral in case of danger signs. And that's why it's important that when they go back home, the families and the health workers are equipped to identify the danger signs and come back to the newborn care unit earlier than later. That got into the system the follow-up of the newborn care units. 5 follow-ups at the newborn care unit in the first year, and the 6 follow-ups by the community worker under the existing home-based newborn care program in the first 6 weeks of life. And in some of the states, we went ahead to introduce a SMS reminder system where the moment the patient is discharged, the community worker gets an SMS that the patient is discharged. And also on the day of follow-up, the SMS reminders are sent both to the family and to the health workers. And some of the quality improvements which has happened over the period of time, and though it's slow because not much efforts have gone around quality initiatives, the focus earlier was to get the coverage, but now the focus is to get the outcomes much better. And a few of the states where we could see the difference is, if you see in Maharashtra, another big state, antibiotic usage in 2016 versus 2019, significant decline. In Uttar Pradesh, the mortality has declined from 2016. And the follow-up, though it's still low at 35%, but has started picking up. Because previously we were not following these babies, they were just going home and we were not knowing what was happening to them. So as I conclude, what were the enablers for the rapid scale-up? So what helped? The first and the foremost thing was the need was there on the ground. Babies were coming and dying in the hospitals. The place of mortality had started shifting in the health facility. And I will just give you an example. I was in last week. I ended up resuscitating a baby in the labor room. The nurse was doing a job, but the ambu bag was not functional. We had to get another ambu bag. The chest expansion started. Baby survived for the minute. But I knew that this baby will not survive most likely. And on 5th day, the baby died. So there is a huge need at the facility level of taking care of the babies who are now coming to us. Second thing was seeing is believing. When the government sees, and this intervention gives a lot of visibility to the government and the politicians, and they take a lot of ownership with that. Competing between the states. States started competing that we have these many units versus we have these many units. They started looking at each other's data in terms of how and where we can do better. Continued support and handholding. As partners, we are often guilty of piloting, selling it to government. Once government says yes, we say our role is finished. Our role starts then. Our role does not finish then. We have to draw that roadmap together. We have to walk the talk together. We have to walk the journey together. And when we do that, we are able to ensure a sustainable scale-up. Ensuring assured funding under NHM for African countries, probably this may still take few years, but there may be some other mechanisms of pooled funding, partners funding, which can sustain it. Standardized designs, HR norms, training pack, reporting, the implementation toolkit. Support on the ground by the academic bodies, the collaborative centers, the professional bodies, and UNICEF, and adapting and evolving as per the need. And lastly, but not the least, is being pragmatic. Sometimes we get too theoretical. We need to be practical. What works? We may fail, but with a margin of 10 to 20%. But if we keep on deliberating for years together and not moving on, that doesn't take us anywhere. And this was when the first units were being built. We got the health minister and the chief minister. And this is again evidence that I had some more hair when, I was a bit young and doing this work. And then the chief minister started asking in the reviews, how many units have come, how many newborns have been saved. So bringing the high level advocacy, and then we had a conference of the national mission where all the mission directors and secretaries were brought to see these units. And then the countries, even the Nigeria team came, the South Asian teams have come, the Mozambique colleagues visited the office, and now NES is also a part of this learning exchange. So what will be the next frontiers for the newborn care as we move ahead? Moving beyond coverage, as I said, to ensure quality. Moving from just survival to early childhood development. And already the follow-up system has been now linked with a big national program called the RBSK program, which includes district early intervention clinics, early screening, identification, and disability limitation. Use of data for targeted action, and moving to the private sector. We started last year with 100 private sector SNCUs in Gujarat covered. And one of the things we learned is that the health insurance supported states and the facilities in the private sector, they can be asked as a trade-off, please give us your data on the key things, the stillbirth, the C-section rates, the antibiotic usage rate, and the mortality in SNCU. So India has a big program called Ayushman Bharat, which funds the private sector. So when you're funding through the government budget, we should also ask and make them accountable for data. And one of the startling things is the gender discrimination is even more in the private sector, with the female admission in private sector even much lesser as compared to the government hospitals. So as I conclude, I would quote our President APJ Abdul Kalam, who said, "Dream is not something that you see in sleep, but dream is something that does not let you sleep." Our government, our partners, UNICEF colleagues in India, and a lot of many people who worked for this had this shared dream. And that's what made it possible. And let's live this dream once again for Africa together. Yes. And as UNICEF, we would be so happy to support this, both from our supply division and the program division. Thank you so much, Joy. Thank you so much to the entire NEST team for hosting me and inviting me. Thank you.
Beautiful. And I see the first and most illustrious hand has already been raised.
But
Barbara, you need to introduce yourself. Otherwise, I will introduce you.
I'm Barbara Stoll. I'm a neonatologist. I live across the street at the University of Texas. I'm the dean of the medical school. That was absolutely breathtaking. And I will say, and Joy knows this, that I started my career in the early 80s working in Bangladesh at a time when maternal mortality, neonatal mortality were unfathomable problems. You could not dream of this, even if it kept you up all night. And I do think that you bring up first and foremost, and this group now looking at scaling up in Africa, the importance of having a big vision and having a big goal and not being daunted by the naysayers who say you can't do it. Because you've shown in a time when 40 years ago you couldn't fathom doing it, but you did it. And let's say the 80s to now is a short period of time in human history. I think you also underscore the importance of impeccable planning and attention to every single detail. But maybe the most important thing is how you garner political will so that, sure, you need foundations, but you need the government behind you because they're the movers and the shakers and can write the check. And I loved your comment about seeing is believing, the early pilot wins that show that you can actually do that before people are willing to go to scale. Some years ago, I was in a small venue where Bill and Melinda Gates talked about they had gone to Washington to lobby the U.S. government to say, we're maybe the biggest foundation in the world at the time, but we're small potatoes in comparison to the needs of government to really make things sustainable. And you've shown that by seeing, you can get government buy-in, both to say that mothers and newborns are important, but to make a sustainable investment. You've also shown the importance of flexibility in both use of funding. I love your, tell us what you need to be paid, and I'll take you out of what seems like a great private sector job to work in the public sector. And finally, how important it is to use data to understand evidence to guide not only investments but interventions to really improve outcomes. And I circle back, and this is what every one of you here, really the power of individuals, individually and collectively, to really make a difference. I mean, this is breathtaking, and what you can now do in Africa is, this really inspirational. So thank you.
Thank you so much.